My name is Reginald Eze. I'm from the Mathematics, Engineering, and Computer Science Department. Um, I'm going to talk about skin biopsy, what it means, and what the implications are. Okay, my talk will just take the following format. I'm going to talk about skin melanoma, which we are all familiar with. I'll give you facts, I'll give you numbers. We'll look at ways of treating skin cancer, the traditional method, and then what we are looking at to be an alternative. I'm going to talk about my research goals, what we've been doing so far, what we've done previously, and then essentially my research is hinged on trying to find out essentially how light travels in human skin. And I'll show you some partial results, and then also I'll talk about the conclusions and the outlook with reference to my research here at LaGuardia and also how it should affect the students. So here are hard facts about cancer, about skin melanoma. So cancer of the skin is one of the most common, is the most common of all cancer that we encounter with. Skin melanoma accounts for less than 2% of skin cancer cases, but it causes majority of skin cancer deaths. It does cause majority of cancer deaths, and this is very worrying. So what do? We have to try to find a kind of a solution. So this is just typical a case where for 2014, this year, these are the facts. It is estimated by American Cancer Society that total melanoma cases in the United States is almost 76,000, out of which 43,000 men are diagnosed, 9,700 women are also diagnosed. Of this number, it is expected that 6,470 men might lose their life because of skin melanoma, and also estimated that 3,200 women might eventually end up, dying because of skin melanoma, which is not a good thing, to even look at. So another fact that we have to be aware of is that skin cancer, it doesn't affect us equally. It is prevalent in some races, as much as we know that we are all not made to look alike, to be the same, especially with respect to skin color. So the lifetime risk of getting melanoma is about 1 in 50 for whites, 1 in 1,000 for blacks, and then 1 in 200 for Hispanics. So the risk of melanoma increases with age. Actually, at the age of 61, that is when it is most, seen. But it doesn't mean that at younger age we are also safe, especially in young women. From the age of 30 is also a problem. It is more prevalent in women than in men. So I'm going to show you essentially a short video of the traditional skin melanoma procedure, how it is
dermis and hypodermis. The epidermis helps prevent most bacteria and other foreign substances from entering the body. The dermis provides support for the epidermis and gives the skin its flexibility and strength. The hypodermis is a layer providing insulation and protective padding. Skin biopsies are commonly ordered for warts and moles, skin cancers and other growths, allergic reactions, bacterial or fungal infections, acne, psoriasis, to numb the area. Shave biopsies are usually performed on surface lesions. During this procedure, your doctor will use a sharp scalpel or formed on surface lesions. During this procedure, your doctor will use a sharp scalpel.
Sorry, what it is here is that essentially the video is not working perfectly. The traditional method of removing skin, malignancy, especially skin cancer growth, is to be able to remove that portion of the skin. Essentially, the doctor will, examine the skin and try to exercise a portion of it to take it under the microscope, to view it under the microscope, and then determine whether it is a malignant or benign. And from there, if it is a benign, then it should be removed completely. This is a situation whereby we wouldn't want to, we're looking for an alternative. And what is the alternative?
Or
Sorry. The alternative here is to look at optical biopsy instead of removing the skin by scalp and then looking at the treatment the way it is done these days. Essentially, what optical biopsy is illumination of the skin tissue with selected wavelengths on a tissue sample. And when you illuminate the tissue with light, you get a back signal. So the resulting spectroscopic signal is investigated to see whether there is a hidden, anomaly beneath the skin surface. So what is the purpose? The purpose of is to non-invasively, because we saw in the previous example, your skin is removed, it's hurtful, some people get scared, you don't want to go through that. So it's to non-invasively differentiate between healthy tissue and diseased tissue, for subsequent, dermatological, surgical, or other medical procedures. So there are options we have right now. What are the options? Most people go through computed tomography, CT scans. Some people go through X-ray imaging. X-ray imaging is not only for the bone, it could be used for, to find a diagnosis and cure for skin cancer. Nuclear imaging and PET scans. The problem with this technology is that they use ionizing radiation, which means in the process of you trying to remove the tumor, you end up damaging cells that doesn't have cancer growth on them. So ultrasound is also another method. And MRI, most of us are familiar with, is also a method that we use to, probe the skin and find out whether it is, safe, it is healthy or not healthy. And these two methods are, use non-ionizing radiation. And the great thing about our method is that it does use non-ionizing radiation, which is just white light. So what is the advantage of the method of optical biopsy? Essentially, to detect disease at an early stage. You wouldn't want to go for cancer removal or for treatment or for photodynamic therapy or for a therapy that you have to lose your hair or, lose weight and stuff like that. You want it to be detected at an early stage and then take care of it. So what is the disadvantage? We have all these problems, but still we have issues with, being unable to detect cancer at a very early stage. Because it's difficult for us to say exactly definitive diagnosis is made. It's difficult for doctors to give you the exact diagnosis. So they all have their own shortcomings. And again, doctors have to, even if when they are sure or when they are nearly sure that you have cancer, they tend to also remove the skin to examine it to make, to be 100% sure that they are not doing the wrong thing. So, let me go back to this, sorry. Here, what we see here is, for example, this mice has a fully grown cancer cell inside it. And we are trying to use a optical biopsy to probe it. So the first thing that happens is that you have the light from laser. Sorry. The laser light goes into the skin, into the mice skin. It probes it. So this is the tumor, made up tumor. This is like, okay, there is a problem here. You want to find out exactly how big, how large it is. Then you use a laser to be able to probe inside. And when you probe, the light goes in, scans it, and then reflects back. When it reflects back, it's collected by an electronic equipment. And then you try to examine to see how big or how large that tumor is. This is second case, whereby you don't want to have a fully grown tumor. What you desire here is to be able to take a look here. This is the first layer of the skin. So skin has stages. So you want to capture the skin, the cancer growth at the early stage. So you want to make sure that it doesn't, go from stage 1 to stage 2, and then becomes something that you have to worry really about. So the essence of this, my research, is to be able to, find out exactly how to deal with the first stage, meaning being able to track the growth of cancer cells on the skin from the initiation stage. So this is a typical setup for a skin biopsy. All we need is a wavelength, a laser wavelength of multiple wavelength. But first of all, we have to be able to understand that wavelength discriminates, depending on where on their wavelength, on their energy, on how you use it, and then how you apply it. Because all wavelength, all different colors, it reacts differently depending on where you shine it. So this is the first. This is just simply, if you take a look here, this is that's the skin sample here. You are trying to illuminate the skin with a fiber and then send the signal back to the computer so that you should be able to see the signal that is coming off from the skin. So that is my area of interest. I'm interested in trying to probe the skin part, and then I focus my energy there. So what happens here is that, scaling this up, the fiber comes in, interacts with the tissue. Again, you have light of different wavelength coming into the skin, interacting with the skin, and then you have a light of different wavelength also leaving the skin surface. That light that is leaving the skin surface goes to this electronic system, is analyzed by the computer, and then, decision is made whether it is coming from a healthy skin or from a unhealthy skin, because we already have the signature of the skin in the computer data bank. One of the most important things about skin biopsy is that we have to understand the relationship between the wavelength of light, its depth in the tissue, because we don't want to misapply a particular color. This is a typical skin section. And if you can see, these are all 200 wavelength all the way to carbon laser, which is a 1080. So they all have different penetration depth. Some of them penetrate beyond the dermis, some of them are absorbed by the dermis, some of them go into the dermis, and some of them goes all the way. Oftentimes, if you take a look at 400 wavelength, the wavelength goes all the way to the dermis. It does not see the epidermis. It regards the epidermis to be transparent, because these are all absorbed by different types of material in the skin, especially the skin chromophores, the blood, the oxyhemoglobin, the hemoglobin, and then the collagen in the skin. They all help to determine how far the light will penetrate. So in designing the skin biopsy, we have to be aware that we have to be able to choose the right wavelength. Oftentimes we choose the near infrared. So for the purpose of our study, we're able to use 700 nanometer wavelength. So essentially, my goal is to be able to develop an optical imaging system for early detection of tumors in human tissue, and to implement a technique that provides an instantaneous in vivo microscopic examination. It has to be on time, it has to be real time, it has to be fast, so that you don't have to wait for the skin to be returned after 1 week from the lab, and you know whether you are sick or not. And this could be done by, allow physician, when it is fully developed, to be able to survey large sections of the skin, and also it will help to reduce a problem of not knowing exactly where you have to interrogate if you're making a decision for, whether to remove a skin that is malignant or not. So what is the key here? The key of, solving this problem is to be able to solve the radiative transfer equation, the equation of radiation transfer. This is a complicated equation. It is an integral differential equation. It has no solution. It has no closed form solution. It has a solution, but not a closed form solution, which means that it doesn't have a formula that describes it. So there are ways of solving this problem. And this has been the problem because the current technology relies on the solution of this problem to understand how skin penetrates in this tissue. So all the equipment we've been using are all based on the design, based on approximation. The current models of the solution depend on P1 approximation, diffusion approximation essentially, which says that light diffuses into the skin. But it has a problem because if you're using diffusion approximation, it means that it is predetermined that the light is already in the tissue. What if it's on top of the tissue? So that approximation does not solve the problem. So what we did was to be able to develop a Monte Carlo simulation of approach which solves that equation completely without respect to boundary condition. It takes all boundary conditions, it takes all scenarios, it takes all dimensional object that you want to, so it's all inclusive. But the problem is that it has no closed form solution again. So you use the computer to play a dice and be able to solve the problem. So you cannot really describe the solution as in terms of a formula, but you could describe it in terms of numbers. It gives you numbers which you could use to do your analysis. So essentially, after solving the problem, we looked at two scenarios. The first scenario was how does light travel in human skin? In doing that, we defined two broad boundary conditions. For the purpose of time limitations, I will not dwell on that, but I will leave it here for you to look at later. We have presumed that the light, when it is going into the tissue, there are two scenarios. When the light hits the skin from this picture, what happens is that it is immediately reflected back into the surface. Oftentimes, the light is transmitted inside. It does some random work inside the tissue. It goes back. You collect it as a diffuse reflection. The one on the surface doesn't really help us because it doesn't interrogate the tissue. So the most important thing that we achieved was to be able to get this profile. This profile speaks a lot about what we have now and what it should be. If you look at the profile here, what we have in most medical devices is the continuous profile, the old profile. The old profile, for example, shows you a continuous profile. This is a plot of 3 layers that are all heterogeneous. So I'm looking at the skin, I'm looking at the epidermis, I'm looking at the dermis, I'm looking at the hypodermis. And what the profile gives me is that I don't know where the dermis is, I don't know where the epidermis is, I just give you absorption profile, regardless. So if someone has a tumor embedded in their epidermis, if you don't know, you might have the risk of doing it differently by applying either an overdose or underdose of the radiation. So this is the new profile that we developed. It tells you exactly the step profile. It tells you exactly the first layer, high absorption, is because of the epidermis, because it contains melanin. The second layer is the dermis, and the last layer is the subcutis, which has a little percentage melanin. So these two profiles are quite different, and this is the reality. But this particular profile, the old profile, is what is prevalent. So this is a backscatter reflection. Again, our profile shows the old and the new. So if you use our profile, our method, you get stronger signal, returning back from the skin, and it is very clear. And then you should be able to make a predictive and a correct diagnosis. this particular graph here is just to show you our program was able to identify layers of skin, no matter how small, because the epidermis is very small. Cancer starts from the epidermis, from the melanin, from the melanocytes. So we wanted to capture the effect of those layers there. So our program is able to recognize 1 micron of thickness of skin. Thinking about that, 10 micron is almost the thickness of human hair. The program was able to recognize that. So no matter where in your skin that's, there's a problem, the program should be able to tell you what is going on. So in conclusion, what did we do and what is in existence? Essentially, what is the approach? The approach is that, first of all, if you use the traditional biopsy, you remove somebody's skin. If you use our method, you don't have to. Advantages. The only advantage the old method has is that it is used for thick skin. Our sample, our own method has capability for thick and thin skin, thin samples. It uses non-ionizing radiation. It is non-invasive. It does rapid measurement, real time. It gives you high spatial resolution from the graphs I showed you previously, and it has a, it has a potential of pre-cancer detection. And then the layers are distinct from what I showed you previously. What are the disadvantages? Essentially, for the old method, those issues, because you don't know which one is the layer, which one is epidermis, which one is dermis, and stuff like that. What is the disadvantage of our method? It has not been subjected to real practice. I remember, I'm a mechanical engineer, so I'm not a doctor. So that's one of the disadvantages. People will ask you, why do you do this? But, this is engineering, and this is mechanical engineering. This is radiation. Okay. What is the outlook? I'm looking at it from the point of view, how do I put this research down? This is a high mathematical tension research. So we're trying to scale it down for our students here to be able to do research, to be able to benefit from what we are doing. My intention is to develop an undergraduate study for NASA New York City Research Initiative, summer programs for 2015. We've been doing that since last year. And to integrate this particular work into my classroom instruction, I will be teaching thermodynamics. I intend to use some of my code for my students for them to be able to do some of the work I've done. And then I will seek research opportunities for, for ongoing research in this area because it's a very vast area. I'm also collaborating with Dr. Yasa Hasibo. He's doing something similar, but he's looking at the sky and layers that are of the order of 1,000 kilometers thickness, but I'm looking at something very small. So it's the same approach, but different, biomedical and atmospheric. Again, it is my intention to use a software, a COMSOL modeling software, to be able to interrogate skin and then see how the program, or how it looks compared to the physical and numerical solution. Because the problem that students has is being able to visualize what is done, what it does. So I will end by thanking the organizers of this program for giving me an opportunity to, it's time constrained, but again, it's an idea of what I'm trying to do or what I'm doing so far, and I find it very interesting and very challenging, essentially trying to relate this to LaGuardia students because it is a vast area and it is something that we also have to think about. Cancer is a killer and we should be able to, work hard to, find a solution as much as we can. Thank you.